All right. Hi, guys. Thank you. Sorry for the late start. But today we're going to be talking about understanding meth addiction in treatment. And we have our clinical director, Rich McDonald, with us. If you guys want to ask any questions at any time, you can just type them into your GoToWebinar control panel, and we'll make sure Rich answers them. And then for handouts, we have a few handouts in the GoToWebinar control panel. So you can download those handouts and learn more about Wasatch Crest from them. I'll let Rich start. Rich, can you see my screen?
Okay, hi everybody. Thanks for joining us this morning. And Kayla, do we have the slideshow? Is it sharing from my computer? Sorry.
It should be sharing from mine.
Okay, perfect. Yep, there it is. Awesome. Okay, thanks you guys. So my name is Rich McDonald. I'm the clinical director at Wasatch Crest. Originally we had Kevin Kirscherman joining us, and he got tied up with a client, and we're always excited to do these things, and especially today, there's some discussion, but not a ton, on the differences between methamphetamine addiction, opioid addiction, alcoholism, and I think it's kind of one of the topics that is interesting to approach, and also maybe something that we could talk a little bit more about. So methamphetamine addiction presents differently than opioid addiction or alcoholism in a few different ways. One of the things that seems to be significant is the risk of psychosis versus some of the other drugs. It's probably a possibility with cocaine and maybe some really significant opioid or alcoholism that might come along with it. But methamphetamine is different in the fact that it disrupts the sleep so badly that a lot of times not only is it changes in the brain that are causing the psychosis, but also it's the lack of sleep. And one of the things that we work on initially with methamphetamine addiction, when somebody comes into us and says, hey, my primary drug of choice is methamphetamine, rarely anymore do we see somebody with only one drug of choice, in all honesty. Maybe alcohol, but somebody comes in, the thing that's often going on is they're 10 to 20 pounds underweight. Sometimes they if they come to us a little bit sooner, they might not be that their body weight might not be that low, but oftentimes they haven't slept, or if they have been sleeping, it's been an hour or two every night. And also the psychosis piece. I think I can give a few examples later on, but methamphetamine's highly addictive, and some of the things that are particularly risky and dangerous about methamphetamine is the way that it responds or what it does in the brain. We know that you can overdose and have a heart attack or a stroke, or it raises blood pressure and heart rate and all of those things, but it also can induce meth-induced schizophrenia or meth-induced psychosis. See a lot of paranoia. We see a lot of depression. One of the things that our psychiatrist talks a lot about is that when somebody's being treated for meth addiction, especially if it's long-term use, they will oftentimes need an antidepressant, probably for the rest of their life sometimes. The brain is resilient, it does heal, but there are certain things that never quite come back. And a lot of times that depression, you're going from the overload of dopamine and the that feeling that methamphetamine gives you. Well, when you take that drug away, the brain's actually not firing in the same way, and people will go through stints of depression, and oftentimes I find that for methamphetamine treatment we're going to be looking at a lot longer stay, they need to be seen or followed closely by a doctor for the mental health factors that come along with that. And it's a difficult drug because of the length of the half-life as well. So if your son or daughter is being treated for ADHD, or whoever's being treated for ADHD, oftentimes, they'll use Adderall and they make it long acting, because normally the half-life would be like 4 to 6 hours, and with methamphetamine it can be 12 to 20 hours, just depending on the way a person's body metabolizes it. So your body gets it and really doesn't know exactly what to do. So, Kayla, next slide. Perfect, thank you. So we talked a little bit about treatment approaches and detox. So methamphetamine detox, for the most part, oftentimes it is maybe some anxiety reducing drugs, or I guess the treatment lingo is comfort meds. Some of the same things we might use for opiate withdrawal, just to help people calm down. Clonidine, we try to avoid using benzodiazepines or anything that also has an addictive component to it. But honestly, methamphetamine, if that's their main drug of choice, we're not worried about a seizure. We're not worried. Really, it comes down to letting them sleep and just taking it slow. And so I had an experience this month that I think has been fascinating. We got a gentleman in. He's probably in his late 50s. No, I guess I know how old he is. He's in his late 40s. And he came to us following a 3-day stay at a psychiatric hospital. He'd never had a history of psychosis, but he came to us. He was super tired. He'd essentially been at the primary mental health facility, did a little bit of detox, came to us very tired. The first week, we had a really difficult time getting him to speak. One-on-one, I could get him to talk a little bit, and he was polite, he was kind, but I could tell that he was having some paranoia, and we discussed that, checked in with him regularly, put him on heightened rounds, wanted to make sure that he was okay. And I met with this gentleman yesterday, and it was fascinating. He said, it took me 22 days. And I said, what does that mean? And he said, he goes, when I first got here, I was really worried everybody was trying to trick me, because I wasn't worried for my safety, but I thought everybody was trying to trick me and they were going to use anything I said against me. And he said, about 2 days ago, I realized that it was paranoia. And I said, well, where the 22-day piece, where did you get that? Tell me more about that. And he said, he goes, I counted back from the last time I used to then. And he goes, I was so worried that everybody was trying to get me to say something that would incriminate me. And which explains a couple experiences I had with him. He was really hesitant to sign his treatment plan, and he did, and it was just a process to get him feeling very comfortable. And he's been participating, but the last few days it's been a totally different experience. And I guess I tell that story because a lot of times we'll see somebody coming in for opioid addiction. They've been to detox, or they're finishing up kind of their detox taper the last couple of days with us, because we are licensed for social detox, and they bounce right back and they're feeling really good. They obviously have the triggers, and we're working on a lot of the relapse prevention skills and trauma and other mental health stuff. But usually if we can get them to day 10 or so, they're feeling great. And it's different with methamphetamine. It's just a longer process. And as far as treatment approaches go, I think a lot of it really is dependent on the individual. We do a lot of rec therapy and a lot of identifying skills or activities that they can find that get them excited about life and passionate, and really try to work on that mood piece as well. Like, what do we do when we're feeling low or anxiety, and really working on all the things that we can do to help them as their brain starts to heal and they start getting back into the real world without using drugs. So do the next slide. Perfect. So, and I've kind of touched on this a little bit already. So the thing that is really changed is the perception that people have about methamphetamine. I know that I had my own biases I brought to the table when I first started practicing as a therapist. The reality is it is definitely an equal opportunity drug. There's not necessarily a socioeconomic class that uses it more, but yet I still will hear from family and friends, hey, I can't believe that my son was using meth. I'll make comments like that it's pretty pervasive and widespread. It's generally inexpensive and it lasts a really long time. And I think we really do approach it from that overall life and well-being approach, helping people to kind of re-identify passions and get excited about life. Long-term therapy, treatment. The other piece with methamphetamine recovery is we don't use Suboxone to treat it or any other maintenance at this point. It's not widely used, at least. And some of the things that work really well with opioids and alcohol don't necessarily help out with methamphetamine. So it really is those basic, emotional regulation, life skills, and getting people back living their life and having a large network of sober support. So the next one. So that is our webinar on methamphetamine addiction. Does anybody have any questions?
It doesn't look like we have any questions. Thanks, Rich. That was great. Just to preview our next webinar, it'll be on the 26th of this month, and our sober living program director will be talking about how we help sober living clients secure employment for when they complete treatment. So look out for an email, or look out for a link to register to that in your emails. And then there is our website, wasatchcresttreatment.com, and then our admissions phone number, which is 24/7. Thank you, everyone, for joining us today. Thank you, Rich. That was great.
Thank you. Have a good day, everyone.